In case of ischemic stroke, we have these dynamic changes according to the time. The ADC will be darkest at 24 hours or 2 days, and DWI will be brightness at 3 days, approximately. And ADC will follow a pseudo-normalization by 10 days approximately. After this time, approximately one week, what we will see is the predominance of vasogenic edema. It's vasogenic edema. What we can see in this case, T2 and flare will be very clear in representing. So, one way to classify these mimics could be using DWI and T2 gradient. DWI could be abnormal, and you have to ask yourself this question: does T2 grade show hypointensity? It means if T2 gradient shows hemorrhage, basically. If that is the case, intracerebral hemorrhage and cerebral venous thrombosis is our first mimics in the list. But if T2 gradient does not show hypointensity, we have this list of mimics that you can differentiate, helping with the clinic. We have epilepsy, hypoglycemia, MELAS, PRES, tumor, demyelinating diseases, Sussex syndrome, even rare diseases like Sussex syndrome and HSV encephalitis. We will see this in detail later. DWI normal could be a cortical subarachnoid hemorrhage in the context of CAA, because there are another causes of cortical subarachnoid hemorrhage. But could be migraine with aura, or this disease that is rare too. It's a headache with neurologic deficits and lymphocytosis. In case of intracerebral hemorrhage, if we see blood in the CAT scan, and you know the time of onset of symptoms, you can apply this knowledge, these causes that you know. But you have to remember too that not always all patients will present in as clear as these. So you have to use the MRI to maybe to narrow the diagnosis in case of malformation, arteriovenous malformation, or tumors, or in case of transformation of infarct, hemorrhagic transformation. That is why aging blood is a concept that is important. Maybe in the first 48 hours, it is more clear the difference between the sequences. Obviously, it will change. The changes depend on time and size of hematoma. But in the first 48 hours, T1, T2, and gradient will be influenced by the content of proteins. In case of T1, T2 will be influenced by the amount of water and the presence of blood products like deoxyhemoglobin, and gradient will be influenced basically by the proportion of oxyhemoglobin and deoxyhemoglobin. So in the case of hyperacute hemorrhage, for example, in which oxyhemoglobin is intracellular, DWI will be hyperintense, and ADC will show restriction. So it mimics the images that we see at the beginning of stroke. But gradient will be our key sequence, because this this sequence will be very susceptible to the presence of deoxyhemoglobin. And oxyhemoglobin transforms in deoxyhemoglobin even in 2 hours, in 1 hour of the formation of the hematoma. So we will see this like a halo, a peripheral halo, that is very thin at the beginning, and then it gets thicker. T1 will be isointense, and will remain isointense, or will increase signal in the second day, and this is because of the increase of proteins in the hematoma, because of the fibrin, because of the contraction of the blood. And T2 will be hyperintense at the beginning because of the content of water or plasma in the blood in a fresh hematoma, and then it will change in the second day, and it turns hypointense, and it remains for a week approximately. So in this slide, we only have to remember that in hyperacute stage, DWI and ADC will be similar to the signal of a stroke. And it is probably due to the nature of the hematoma. But in late subacute, the explanation is complicated, but the blood turns liquefactive, and phenomenon occurs. So DWI and ADC again is similar, like the signal of stroke. But the evolution of the hematoma is in this draw, and you have to remember maybe the first 48 hours, because it's the time that the patient maybe if it is something acute, maybe you will see patients in this window. And in this window, what is important in resonance, that in T1 is isointense. So T1 is not helping, but T2 will change dramatically from hyperintense to hypointense. And T2 gradient will show this halo, this thin halo, and then this halo will predominate because of the deoxyhemoglobin. And remember that in late subacute is another time that is in which you need the history, and you need the comparison with CT, because it's hyperintense in all sequence, even in T2 gradient. But it's something that is like a light gray. So in this case, we have a woman that presenting with left hemiplegia and left homonymous hemianopsy, and DWI shows heterogeneous signal. And ADC shows a subtle hypointensity. So this could be controversial, but thinking in a stroke. But in this image in FLAIR, this is hyperintense. And in a hyperacute moment, that could be only a hematoma. And this is our key sequence, the T2 gradient. T2 gradient will show in 12 hours, in the first hours, will show this thin halo of deoxyhemoglobin. So this is a hyperacute moment. In case of cerebral venous thrombosis, as you know the aging of blood, you can apply this knowledge in this kind of aggregation of red blood cell that is a thrombus, but with some difference, because in case of thrombosis, you don't have the final phenomenon, that is the deposits of hemosiderin in macrophages, but the other stages of the sequence could be the same, could be very similar. DWI will be heterogeneous. DWI can mimic a stroke, but T2 gradient is our key sequence to show the thrombus with this sign of blooming and enlarging of the occluded vein. And this is because of paramagnetic phenomenon of the deposit of deoxyhemoglobin and then metahemoglobin that is very restricted indeed in that area. So it's isointense in T1 and hypointense on T2 and flare because of the lack of content of plasma since the beginning. In this, maybe this is different to the previous image. In the subacute stage of CVT, 1 week or 2 weeks after the hemorrhage, after the thrombus, is hyperintense on both in T1 and T2. And this is because this phenomenon occurred because of extracellular metahemoglobin. This is a physics explanation that is very far of our topic. And in chronic phase, always T2 gradient, or typically T2 gradient will be hypointense. This is a place, the special place where we will see this pathology. DWI is variable, lack arterial distribution, talking about the damage in parenchyma of this thrombus, and has no prognostic value. In this case, we see a vasogenic edema. It's clearly a vasogenic edema because it is bright, or it is hyperintense in ADC, and is hyperintense in flare. And it's a woman with seizures with stage 4 stomach cancer. And in flare, we can see this thrombus in the transverse sinus. And after 4 months later, show nearly complete resolution of the vasogenic edema. And this is a characteristic of vasogenic edema that we will see in these stroke mimics, that this is more probably that resolves, which is not happening in cytotoxic edema. In this case, only a subtle alteration in flare lead us to request a venous study, a MRI, or time of flight could be another option, but maybe the best is using contrast, and even CT, venous CT could be a good exam. These are the areas, the drain, the veins, the main veins, and this central area is what we have pathology in case of deep cerebral veins, like in this case. In deep cerebral vein thrombosis, we can see bilateral alterations in thalamic, but in this case is asymmetric, and the basal ganglia are compromised too, the right thalamic, and we can see this hypointensity in flare, hypointensity in ADC. The signaling in diffusion is heterogeneous. So in gradient, we will see very clearly that this is an hemorrhage. So this is an edema and hemorrhage in the context of a thrombus in the Galen vein and cerebral internal right cerebral internal vein and straight sinus. but this signal, this signal is hypointense because of the presence of blood and this presence of blood will cause distortion in the images of DWI and ADC. So this could be an example of T2 shine, the opposite of T2 shine through, that is T2 dark through. When you see in the original image in T2, you find a hyperintensity, and you apply DWI, you will have a remain of this hyperintensity related to vasogenic edema. You will have a remain of this phenomenon in the final image in B1000, and this is to shine through. And in this case, we have the opposite phenomenon, because in the original image you have this distortion of the magnetic field, and because of the hemorrhage, and this hypointensity will remain until the end, final product. And this is a T2 dark through. No? The same is happening in ADC, and this is not a restriction. This is only an artifact. In case of epilepsy, when we have Todd's palsy or posictal aphasia, it can mimic stroke. In status, this is especially true because you can find damage in cortex pulvinar and hippocampus, and it could be related to vasogenic edema and because of cytotoxic edema. And this is due to hemodynamic and metabolic changes, respectively. So you can see a variable. You can see a variable DWI. It could be hyperintense with variable ADC. It depends of the severity of the damage. Flare and T2 will be hyper intense because of cortical swelling only. There are phenomena in perfusion that you can see, you could see like a mild hyperperfusion in the region, and there are alterations on the brain-blood barrier too, and this lead to contrast enhancement. So in follow-up, you can find brain atrophy or cortical laminar necrosis or mesial temporal sclerosis. So this could help. When you see in the very acute moment, very hyperacute moment, these kind of lesions, like in DWI, in pulvinar, and in the cortex, and that don't follow a arterial territory. In this case, in the hippocampus, and subtle restriction, because of this is maybe not totally cytotoxic edema. It is not lost tissue, and subtle alteration in flare. You can think in this kind of damage. In case of hypoglycemia, it can be a bilateral and symmetrical white and gray matter lesions, and it depends of the damage of the pathologies of the patient. This could happen in patient that is with encephalopathic or with alcoholism background, and DWI lesions that predominate in white matter. When it is in white matter, along corticospinal tract, splenium, or corpus callosum, this could be a better prognosis than in case of motor cortex or basal ganglia or hippocampus. This is related to the original slide about that kind of edema, because in the first case, this could be more intramyelinic edema. In this case, it's more cytotoxic edema. So thalamus, hypothalamus, hypothalamus and brainstem and cerebellum are generally spared. Maybe in the case of thalamus, because it has a great metabolic activity, and it resists better the process that happens with hypoglycemia. And this is very fast, this damage. So in DWI hyperintensity, with decreased ADC could be frequent and is for worse prognosis. But this is before T2 and flare hyperintensity. So this is not explained by vasogenic edema. It's another mechanism. And no abnormalities on perfusion will discharge absolutely a stroke. And there are enhancement on post-gadolinium in the areas. In spectroscopy, mildly reduced NAA is with no lactate peak. That is why I say that this is something that is very fast. This is not an aerobic metabolism. It's another kind of mechanism. And outcome depends on the severity and duration of the event, but also on the extent and location of lesions on DWI, the original DWI, and if these do not regress on follow-up. This is an example. In this case, in DWI, in this woman with hypoglycemia after abdominal surgery, you can see this hyperintensity, some hyperintensity in the caudate in DWI, but it's not with restriction in the ADC. So maybe this could be of better prognosis and other kind of lesion. And this is another lesion that you can see in the splenium of corpus callosum. And this is again white matter. In this case, if white matter don't have ADC correlation, this could be something that can recovery. In case of MELAS, this disease is a metabolic disease. It's a failure in the phosphorylative oxidative chain in mitochondria. So this is an stroke-like episode before age of 40 with encephalopathy, seizures, or dementia. But in this case, is lactic acidosis is one main feature, and red muscle fibers in biopsy. So in DWI hyperintensities with increased ADC will regress, follow up, but in case of decreased ADC will persist. This is properly a cytotoxic edema. But lesions do not follow vascular territories. It's not a classic stroke. Often will spread, will follow a progressive pathology. No? In flare and T2, we will see swelling and hyperperfusion in vasodilation in the studies of perfusion. And in case of spectroscopy, we will find elevated lactate peak and decreased NAA. But even in a normal brain, so this is a metabolic failure that is broad in all the brain. This is a special use of spectroscopy. The other special use of spectroscopy is the tumors. But in this case, you can see this patient with this area in DWI and subtle alteration in ADC. That is why this patient recovered after 2 months. After 2 months. But in this case, these patients had left homonymous hemianopsy, and 3 months later, this other region get affected and has the opposite right hemianopsy, homonymous hemianopsy. With the perfusion, you can see this increase of perfusion in the area to help this area with that metabolic failure. This is another case of MELAS. In this case, the temporal, but also the parietal lobe was compromised, and this patient has a hemi-neglect with subtle alteration in ADC, and even the pulvinar portion get affected. This is PRESS. PRESS has causes that are well known, but the typical presentation is hyperintense lesions on T2 and FLAIR with predilection for posterior region and symmetric distribution, but PRESS not always is reversible and not always is posterior. So what we can find is that DWI can be abnormal with mixed pattern. This is a phenomenon of vasogenic edema, but without a disruption of the brain-blood barrier. This is a special pathology in which the regulation of the vascularization is failing. So in this case, it's not the typical featured the enhancement with gadolinium. And T2 gradient can be positive if there is a subarachnoid hemorrhage and intraparenchymal hemorrhage, but in this case, it could happen, no? Because the blood barrier is damaged. Like in this case, it is some posterior and bilateral compromised. In this case, with heterogeneous signaling in DWI and heterogeneous signaling in ADC. But in this case, brain-blood barrier is damaged because the gadolinium is taken up. Yeah, it's taken up. It's not the most of the case, because in this case it's more typical. The lesions are bilateral, are very generalized in the parietal, occipital, and frontal even. Extreme capsule and external capsule are compromised too.
Subcortical.
Yeah, in this case it's subcortical. Yeah, it's another feature. And in this case we don't have ADC, but in this case you can see that it's vasogenic. It's predominantly vasogenic. Another cause, another mimic could be tumors, especially if it is small or including the arterial territory and involving the cortex. In DWI shows variable signal intensity, and this is a characteristic of primary or secondary tumors. And ADC is inversely proportional to cellular density. This is a special characteristic. And DWI is hyperintense, and ADC is hypointense in 3 tumors, especially in 3 tumors. It's like a stroke in primitive neuroendocrine tumor, in lymphoma, and in medulloblastoma. But the perfusion is increased. And the spectroscopy may show an elevated peak of choline. In a spectroscopy, choline is related to membranes, only cellular membranes. And if there are a lot of crowded cells in the region, choline will increase. But the reduce of NAA talk about reduce of neurons in the area. This could happen too in multiple sclerosis, but in different level. So this is the only to show that this is the normal spectroscopy. This is the peak of choline, and always the peak of NAA is higher. This will be inverse in case of tumors. In this case, glioblastoma with subtle ADC, with subtle hyperintensity in ADC, hyperintensity, subtle in FLAIR, but with taking up of contrast of gadolinium, and hyperperfusion in the area in this case. In demyelinating diseases, the DWI sometimes demonstrate hyperintensity and generally associated with an increase in ADC, but sometimes some can be decreased, and most lesions involve white matter. So in T2 flare could show multiple white matter lesions of previous process in the following areas. This is what you know. And in contrast enhancement, T1 will show gadolinium uptake if it is acute. And in spectroscopy may help if you see reduction of NAA and peak and choline, an increase of choline. But in this case, it's because of pro-inflammatory cells in the region. This is an example in 17 years old women with left homonymous hemianopsy, and DWI show this hyperintense. In this case, there is no ADC, but you can see in flare the lesion, and you can see there is uptake of enhancing with gadolinium with normal vascularization. Susak syndrome is a rare disease. It's a retinocochlear cerebral arteriopathy, probably caused by the obstruction of precapillary arterioles. And this happens in brain, retina, and inner ear. So with a strong predilection in women between 20 to 40 years, the DWI in acute lesions appear like as 3 to 7 millimeters and spread in both white matter and basal ganglia. In flare is high signal intensity too. But the restriction of the lesions could help if you want to know if this will be of good prognosis or not. And this is something pathognomonic, is the snowballs or the compromise of the corpus callosum in the splenium, in the center of corpus callosum, to differentiate with multiple sclerosis. And this is another sign that is internal capsule appearing of a string of pearls. We will see both. In this case of the pearls in the internal capsule in 23 years old men that is hyperintense in DWI, and with restrict diffusion on the diffusion weighted in this case. But in this other case, this is a pathognomonic signal, and this is in the center of the corpus callosum. This is not in the undersurface or in the septal interface of the corpus callosum, like in the multiple sclerosis. No? This is another way to differentiate. In this case, with restriction. And herpes with bilateral temporal lobes and basal ganglia typically spared. DWI is more sensitive to highlight the parenchymal lesions with restricted diffusion, because this is a cytotoxic edema in the acute phase with compromise of the brain-blood barrier, and even with the presence of blood. If that happens, T2 gradient will be our key sequence. In this case, with a cortex compromise in the temporal, in the insular region, and with contrast, with taking contrast in this part, revealing meningitis. And this is another pathology when DWI is normal. In this case, cortical subarachnoid hemorrhage, but in the context of cerebral amyloid angiopathy. with the deposition of amyloid beta in the wall, the cortical and leptomeningeal arteries will suffer damage, and those damage could be in the convexity subarachnoid hemorrhage, in form of convexity subarachnoid hemorrhage, and can be associated with transit focal neurologic episodes, and could mimic a stroke. These amyloid spells could predict an early risk of symptomatic intracellular hemorrhage. So that is the important clue about this, that in acute convexity subarachnoid hemorrhage, the T2 gradient will help, and the T2 gradient will help to show the hemosiderin in the place, in the chronic hemorrhage of the place, and that could be related in the future with the ICH. In this case, 68 years old women with subarachnoid hemorrhage, with normal DWI, normal ADC, but this signaling flare will reveal a hemorrhage, and in T2 gradient we can see this hypointensity or microbleed that spare the basal ganglia. No? That is typical of the CAA. And this is another case where 2 years after this lesion that is very similar than what we saw. 2 years later, has this ICH and this deposit of hemosiderin in gradient, and is bilateral. And this is the original lesion, and this was in an asymptomatic patient seen between both episodes. In this case, this patient has only episodes of right hand paresthesia, recurrent episode of right hand paresthesia. Another differential of normal DWI, but this is not completely true, because this is not an alteration of DWI like an stroke, like big DWI areas, but in migraine we know that there are lesions, very small lesions in flare, especially with increase of age, and it is this is a field that is in research, in active research. But less than 30% of migraine attacks are preceded by an aura. And in this case, the aura could mimic a stroke. The T1, T2 flare are unremarkable, that is true. And perfusion in acute migraine could be decreased in some studies, but some other studies say that this is not completely true in all patients, and some studies report that there is hyperperfusion in the moment of the headache. But in this stage, we can differentiate for this quality of a stroke. No? And TOF MRI could reveal distal loss of visibility of the arteries. If this happens, could be true about these changes that literature say. In this case, for example, there is a narrowing of the arteries. There is another subtle sign that is something related with this alteration of perfusion. In this case, more even if the patient has this patient has language deficit and sensory motor deficit too. So in this case, it was hypoperfused, And this signal that is very subtle is the increase of diameter of the venous, of the place, of the region. This is another rare disease. This is headaches with associated neurologic deficit and lymphocytosis with normal DWI. In this case, temporary recurrent neurological deficit, moderate to severe with cerebrospinal fluid lymphocytosis and elevated proteins and increased opening pressure make us think on this. And no arterial occlusion, but hypoperfusion in more than one arterial territory. So in this case, the territory will be compromised in an area that is more than one area. With hyperintensity in flare, and some hyperintensity in arteries on flare. That is something that is characteristic in this case. So this is the algorithm that we have just covered. And first, always think in DWI and what is happening in DWI, and then if it is abnormal, if it is normal or abnormal, it depends of gradient to classify these other pathologies, and this is the place, the special place that has a stroke in all these algorithms, because it could be normal in DWI in the first minutes, in the first hour even, and could be with T2 gradient normal features. And this is the bibliography that you can see this. You have any question?
Thank you, Charles. Maybe just one question. Yeah, you comment about the B100. I don't know if you can, tell a little bit about the B100. I think it's a more specific, right, DWI?
Oh, the B0 and the B100 is what we use to form the image of DWI. So in the formation of the DWI, you have to know that at the beginning is B0, that is basically a T2. It's basically a rough T2.
Okay.
And this sequence will be manipulated to disappear all the water that is not water restricted, and then will you will obtain this B1000. But this B1000 can have a signal alteration of signal of the original B0. This doesn't happen in case of a normal tissue, normal previous tissue, like in stroke, for example, in any case of a stroke where the patient was normal previous, and you can see that in B0. In Covenant, you have the option of see the B0 and B1000. And this is not normally known for all the specialists, but this is very interesting, because in B0 you can see any hypointensity or hyperintensity, and that could be T2 shine through in the final imaging. In the final imaging that you see is B1000, and ADC is a later process. ADC is another process that disappear or take a minimal level those alteration of the signal. So ADC has a quantitative value. ADC is a very very reliable in that sense. and
Okay.
you can measure that value even.
Okay, thank you.
Thank you so much. That was a great presentation. Would you mind sharing it with us so the residents that were not here today could have it also, because it's going to be very useful for the board, for the ride. It was a really good presentation. Thank you.
Thank you, Dr. Avila. Thank you guys.